So, our next session, we're delighted to welcome Mr. Luke Nicholson to our conference this year. Luke is a consultant ophthalmologist and medical retina specialist at Moorfields Eye Hospital, London, where he serves as Director of the Medical Retina Service. His expertise spans clinical leadership, research, and national policy development in ophthalmology. Today, he will be discussing the current landscape in the treatment for wet macular degeneration and exploring future treatments for both wet and dry macular degeneration. Luke will be taking questions from the audience after his presentation, so please add any questions you have for him in the chat box as we go. And now we'll hand over to Luke.
Thank you for the kind invitation to speak in this wonderful conference. It's truly a privilege and honor to present this. So I am Luke Nicholson. I'm a consultant ophthalmologist at Moorfields Eye Hospital, where I specialize in medical retina, which means I focus on diseases that affect the retina. That's the light sensitive layer at the back of the eye. I also lead the medical retina service in Moorfields. And over the next 25 minutes, I'll be talking about a condition that many of you may be familiar with, age-related macular degeneration, or AMD for short. It's one of the most common causes of vision loss in older adults, and I'll be walking you through what it is, how it progresses, and what treatment and support are available. I'll cover several key aspects of AMD. First, I'll explain what it is and outline the different forms of the disease. I'll then focus on wet AMD specifically, discussing how it was treated in the past, what current treatment options look like, and where we're heading in terms of future developments. After that, I'll turn to dry AMD, exploring what we can do right now to manage it and what promising treatments are on the horizon. I know this is a pre-recorded session, but I will be holding a live online Q&A at the end, and I'll do my best to answer your questions and provide clarity on this important condition that affects so many people. Before we dive into AMD itself, it's important to understand a bit about the structure of the eye. The retina is a thin layer of tissue at the back of the eye that detects light and sends visual information to the brain via the optic nerve. It's essentially the eye's sensor, like a film in a camera or a chip in a microphone. At the very center of the retina lies the macula, and this is the part responsible for our central vision. The vision we use to read, recognize faces, and carry out detailed tasks. It's actually what allows us to function independently in daily life. Now, AMD is a very common condition that affects the macula. It exists on a spectrum from early changes that may not cause symptoms to more advanced stages that can significantly impair vision. Globally, AMD affects nearly 200 million people, and it's a progressive condition, meaning it tends to worsen over time. The speed of progression, however, varies from person to person, but a small proportion will go on to develop late-stage AMD, which can cause substantial vision loss. In the UK, data from 2012, so 13 years ago, estimated that over 500,000 people were living with advanced or late-stage AMD, and that number is likely to be much higher today. When we look at specific forms of late AMD, about 51,000 people are diagnosed each year with the dry advanced type, geographic atrophy, and another 46,000 are diagnosed with the wet or neovascular form of AMD. The risk of developing AMD increases with age. Smoking is a well-established risk factor. And in studies in the UK and Australia, the annual incidence of wet AMD in people aged over 50 and above was about 1 to 1.5%, but this rate triples after the age of 75. So let's begin with the earlier stages of AMD. In early AMD, we see the presence of drusen. These are yellowish deposits made up of lipids and protein that accumulate beneath the retina, specifically in a layer called the Bruch's membrane. Now, small drusen are actually quite common as part of the normal aging process and don't necessarily mean someone has AMD. However, when drusen become larger, more numerous, or start to merge together, it becomes confluent, this can signal early or intermediate stages of AMD. What does this mean in terms of risk? Well, in a large UK-based study, people with early or intermediate AMD had 2 to 3 cases per 100 person years for progressing to late-stage AMD. That risk is higher if one eye already has advanced changes. It's worth noting that this study was based on hospital records, may be slightly overestimating the risk, since people attending hospital clinics often have more severe disease than those of the general population. Now, we know it comes in two forms of late-stage AMD. The dry AMD is the more common type, accounting for 85 to 90% of cases. It tends to progress slowly over time, and in dry AMD, the cells in the macula gradually break down. Small yellow deposits, as we said, drusen, build up, and these can cause blurred vision or distortion when it's significant. In wet AMD, simplistically, although less common, 10 to 15% is more aggressive. It occurs when abnormal blood vessels start to grow underneath the macula, and these vessels are fragile and leak fluid and blood and affects the vision. A helpful way to picture the difference is to imagine the retina as a canvas. So in dry AMD, you have a canvas that slowly fades and becomes patchy over time, but in wet AMD, it's as though someone spilled water or ink and causing a rapid change or distortion in the image. When AMD progresses to its late stage or advanced stages, it typically takes one of two parts. One, in some cases, the accumulation of drusen interferes with the oxygen supply to the outer layers of the retina. Over time, this lack of nourishment causes the retinal cells to degenerate or stop functioning properly. You can think of it as the retina struggling to cope, and eventually certain areas shut down, and this leads to a form of advanced dry AMD or geographic atrophy. And geographic atrophy tends to progress slowly, but the rate can vary depending on several factors, including genetics, lifestyle, and the specific pattern of atrophy. It causes gradual loss of vision or central vision, and often starting at small blind spots that expand over time. And GA, or geographic atrophy, is now formally recognized as a distinct subtype of late AMD. The other pathway to advanced AMD is the body's attempt to actually rescue the struggling retina. So when retinal cells, particularly the RPE or Mueller cells, experience any oxidative stress, so they're under stress because of low oxygen levels, they send out a distress signal called VEGF, vascular endothelial growth factor. And the idea of this chemical, VEGF, is to promote growth of new blood vessels in an effort to bring more oxygen and nutrients to the starving retina. In theory, it's a helpful response. But here's the problem. So these new vessels, called neovascular vessels or neovascular membranes, don't grow in an orderly fashion. They are like well-meaning but unruly children, eager to help but not quite following the rules. So if you ever watch your kids or grandkids try to help in the kitchen, you'll know what I mean, because they mean well, they try to help, but they leave a mess. That's pretty much what these new vessels do in wet AMD. So these abnormal vessels tend to leak fluid, blood, leak, and disrupt the delicate structure within the retina, especially the macula, which is responsible for our central vision. And this form of AMD is known as wet AMD or neovascular AMD, and it can cause rapid and severe changes in vision, as you can see here from the cartoon diagram. Historically, our approach to treating wet AMD was understandably more drastic and desperate. Wet AMD progresses much faster than the dry form, often causing significant vision problems over weeks to months. And without treatment, many patients experience permanent loss of vision within 3 to 6 months. So early treatments were not aimed at restoring vision, but aiming at slowing down the progression and damage. And one of the first approaches was submacular surgery, basically physically removing the abnormal blood vessels from beneath the retina. So this involves detaching the retina and extracting that membrane that's causing the leakage and taking it out. So while it addressed the root cause, it was a high-risk procedure. And clinical trials showed no real difference. So it's not really a thing that we carried on doing. Next came laser treatment or focal laser treatment. And this is used to scar and coagulate these naughty blood vessels and preventing further growth. But as I just described, unfortunately, this method wasn't selective. The laser not only damaged the offending vessel, but also the overlying retina, leading to rapid worsening of vision. We then progressed with a more refined technique called photodynamic therapy. And this involved injecting a drug called verteporfin into our bloodstream. The drug would accumulate in abnormal vessels, and a non-damaging laser would then be used to activate the drug, causing these blood vessels to close off. Sounds very good, and in fact, it was a good idea, and it was a major step forward, and it allows us to start targeting the problem while minimizing damage surrounding the retinal tissue. It still wasn't perfect. Some patients still lost vision because the blood vessels of the retina started closing off as well, and there was recurrences. But compared to earlier methods, it offered hope and became the mainstay of treatment until the development and introduction of injection therapy, which I'll touch on in the next slide. So again, given the limitations of earlier treatments, it became clear that we needed a more targeted approach, one that could stop the disease process while preserving vision and minimizing collateral damage. Laser therapy had its place, but the risk of vision loss remained high, and what we needed was a way to intervene at the molecular level to block these signals that were driving the abnormal blood vessel growth. And the breakthrough came when the development of biological drugs, compounds produced in cell cultures that act like antibodies, are designed to bind to specific targets in the body. In the case of wet AMD, the target was VEGF. We spoke about this, and that's the chemical that promotes the new blood vessel growth. Interestingly, the first drug that showed promise was bevacizumab, also known as Avastin. It was originally developed to treat colorectal cancer, cancer of the bowel, where VEGF also plays a role in tumor growth. When it was given through the bloodstream, Avastin was found to have a positive effect on wet AMD, but because it circulated throughout the body, it carried a risk of systemic side effects. So the next logical step was to localize the treatment, to take a small dose and inject it directly into the eye, where it could act precisely at the site of disease. This approach dramatically reduced side effects and produced excellent results in preserving and improving vision. And this marked a turning point in the management of wet AMD. And for the first time, we had treatment that could halt the disease, preserve independence, and transform outcomes for patients. The first license for eye use, anti-VEGF specifically, was developed for the eye, was Lucentis or ranibizumab. It was a major milestone in retinal medicine. Administered directly into the eye, Lucentis delivered excellent results. Unlike previous treatments with photodynamic therapy, which often still led to vision loss, Lucentis changed the game. With Lucentis, about 90% of patients maintained their level of vision, and a dramatic improvement was also noted in about 30 to 40% of patients. And this is something we hadn't seen before in AMD treatment. And the shift was so profound that clinical trials began to focus not just on stabilizing vision, but on vision gain as a primary outcome. And this was revolutionary in the field of medical retina. While not every patient experienced improvement, the key benefit remains preservation of vision. Wet AMD is still a progressive disease, and without treatment, it can lead to loss of vision. And anti-VEGF treatment gives us the ability to slow or halt the progression, helping us maintain our vision. While we now have effective treatments for wet AMD in terms of stabilizing vision, the key challenge is not just the medication itself, but the pathway surrounding treatment. And this is a chart from the National Ophthalmology Database AMD audit published by the Royal College of Ophthalmologists in the UK this year. This highlights a key finding. What you're seeing here is vision at presentation when they started treatment on the left, and 1 year later on the right. And what's key here is the better the vision at the time of diagnosis, the better the outcome after 1 year. In other words, if we catch AMD early or wet AMD early, we have a much greater chance of preserving vision. While some patients do experience improvement, the main goal is preventing vision loss. That's why early detection and rapid access to treatment is critical. The NHS has put processes in place to help expedite care, but we're still facing challenges, pretty much around staffing, clinic capacity, and resource allocation for this condition. These system-level issues can lead to delays, and unfortunately, even short delays in treatment can result in changes in vision. It's an area where continued investment and innovation is needed. Now, delivering effective care for wet AMD isn't just about having the right drug, it's about having resources and systems to deliver the treatment in a timely manner. We understand the challenges with capacity, and the development of newer treatments has focused heavily on durability. So the timeline you can see on the left shows the number of new different drugs that have been coming to that's been developed and arrived in the market and we have been using. And what we see with the newer drugs is durability, how long a drug can control the disease between injections. This is especially important because wet AMD often requires ongoing treatment over many years. Initially, treatment is followed by treatment is delivered in a loading phase, so 3 to 4 injections. And this is then followed by a stabilization phase, where it's given as and when required. However, most patients require treatment over a number of years. Therefore, we've moved on from as required stage to a treat and extend. So we treat and extend the intervals. And this slowly extends the intervals between treatment. Therefore, the intervals are key, and longer acting drugs lead to less frequent injections. That's why newer drugs have focused on extending treatment intervals. So agents like faricimab or high-dose Eylea have shown promising results in extending the intervals to 12 to 16 weeks in some patients. However, importantly, these newer therapies often offer comparable vision outcomes to the earlier drugs while needing less injections. We're now entering a new phase in AMD treatment with the patents of the earlier drugs coming to an end. So these are drugs like Lucentis, or more importantly, Eylea, which has been used for more than a decade, the patent of which has nearly ended or will be ending soon. And this leads to changes in the drug availability. So with the patent expiry, other biotech companies are now permitted to manufacture biosimilar drugs. These are biological drugs that are highly similar to the original. They're not identical, but they're very similar in terms of producing the same safety profile and same visual outcomes and same intervals. And because these are complex molecules, these biosimilars must still undergo rigorous clinical trials to demonstrate comparable safety and efficacy before getting approval. So the key benefit with these biosimilars is competition, because multiple companies can now make it, and this leads to lower costs. This can improve access to treatment. This can make it more affordable for healthcare systems and patients, and without compromising on clinical outcomes, because it delivers the same benefit as we've been receiving and benefiting in the last 15 years. So alongside biosimilars, we've also discussed the rise of longer-acting newer drugs. And it's crucial to identify who's suitable for which agents. The longer-acting drugs is fantastic and good, but even the older drugs did really well for a large portion of patients. So it's about understanding who benefits from which drug. And using the right drug for the right group of patients, we can extend the treatment intervals for patients who need it more frequently with the longer acting drugs. And patients who do well as well still get the same benefit if they're not needing frequent injections with a biosimilar, for example. And that saves the service and the NHS money to reinvest in the service to deliver treatment in a timely manner, deliver treatment earlier, which is key. Now, the future. So the future of Wet AMD is exciting and continues to offer real hope for patients and clinicians alike. So most of our therapies have focused on blocking VEGF, the key driver to abnormal blood vessel growth. And now newer treatments are looking at different ways to deliver treatment or different pathways to block or to fix. We're also rethinking how we deliver treatment instead of just injecting it in the eye, how we can improve it, and we'll talk about different approaches. And lastly, gene therapy, which is probably the most exciting development, and this looks to reprogram cells within the eye to produce therapeutic proteins continuously, and therefore potentially offering long-term control of the disease with just 1 or 2 treatments. While still in the early stages, gene therapy could dramatically reduce the need for repeated injections and change the way we manage AMD altogether. These innovations reflect a broader shift from managing symptoms to modifying the disease itself. And while challenges remain, the pace of progress is encouraging. So let's look at some of the new and emerging treatments for Wet AMD, looking at different pathways that are currently in clinical trials. So first we have OPT-302. This drug is used in combination with ranibizumab, which many of you may know as Lucentis. While Lucentis targets only one type of VEGF, OPT-302 goes further. It targets VEGF-C and D, which are involved with the whole process as well. So phase 2 trials shows that the combination of this with ranibizumab to have a better outcome, and now phase 3 trials are on the way. Next is EYP-1901, which is vorolanib, and this is a different inhibitor. It's not a VEGF, it's a tyrosine kinase inhibitor to start, but it impacts and targets VEGF later down. And while what's exciting is the sustained delivery system, Duracert, which is a tiny bit that is injected into the eye that delivers the drug slowly. In the phase 2 study, more than 60% did not require additional treatment at 6 months, which is fantastic. In another promising drug, axitinib, OTX-TK1, I'm sorry about the names, and this is also a tyrosine kinase inhibitor, and this is delivered through a hydrogel implant called Expaxly, which slowly releases the medication as well. And in phase 1 study, 73% did not require additional treatment, again showing how the potential for less frequent injections. Delivery systems, we are used to the injection into the eye, and that's what we've been doing. And currently, most AMD injections are given, as I said, into the vitreous. But researchers are now exploring new ways to deliver this, which is less invasive and more comfortable or longer lasting. And the first is shown is delivering in the suprachoroidal space. This is a tiny area between the layers at the back of the eye. Injecting drugs in this space potentially can have a positive effect and last longer. The next is something that many people ask about, which is eye drops, which we've dabbled, but there's some new potentials. So one drug being tested is a nanocrystallized antibody, or not antibody, I shouldn't say that, tivozanib, which is a different drug. And this is being developed to treat conditions like diabetic macular edema, and if successful, could be an option for AMD as well. Finally, we have the port delivery system, and this is a small implant placed in the eye, which acts like a reservoir that slowly releases the medication. So instead of monthly injections, patients may need refills of that reservoir every few months, or hopefully every year, or every 6 months. And this then releases the drug and has its benefits. So it's less frequent visits in the hospital. Again, these innovations are still in development in different phases, but they reflect a powerful shift towards more patient-friendly care that's better for your daily activities, giving you more freedom to have more time between treatments. Now let's look at something that's generating a lot of excitement, of course, the gene therapy field. So gene therapy, as I mentioned, is reprogramming cells inside the eye to produce their own treatment, essentially turning the eye into a miniature drug factory. So instead of repeated injections into the eye, the goal is to deliver a single treatment that provides long-term control for wet AMD. So several gene therapies are currently in clinical trials. And here are 3 of the most promising. RGX-314 delivers a gene that produces ranibizumab, the same drug used in Lucentis, and this is delivered in the suprachoroidal space. In trials, 50% of patients didn't need any more treatment after the first injection. Ixo-vec, which is a different gene, delivers a gene that produces aflibercept or Eylea, the drug in Eylea. And at 2 years, 50 to 80% of patients were able to go without additional treatment, which is highly impressive. 4D-150 is a dual-action therapy that targets both VEGF-A and C. And in here, at 9 months, 80% of patients didn't require further injections. So these therapies are still in development. They're still in early stages, but they represent a paradigm shift, moving from frequent treatment to long-lasting potential one-time solutions. So for patients, this could mean fewer appointments, fewer injections, fewer disruption to your daily life, and greater independence. Now, dry AMD, or its advanced stage called geographic atrophy. This occurs when cells in the center, as I said, degenerate and stop functioning. And what you're seeing here is a visual representation of how GA progresses over time. Each circle shows the retina, with the yellow-white areas representing regions of atrophy. As you move from left to right, you can see how these areas expand and affect central vision. Now, it's important to focus on the goals of managing AMDs. The first goal is to optimize vision. First, while we may not be able to reverse the damage, we can help patients make the most of the vision they have. This includes using low vision age, magnifiers, enhanced lighting, electronic reading devices, or even smartphone apps designed to improve contrast and readability. These tools can really make a difference. The second goal is to reduce progression. One of the most important modifiable risk factors is smoking, and smoking increases the stress to the retina and accelerates progression. So stop smoking is one of the key measures and most effective things we can do. These strategies, combined with regular monitoring, nutritional support, can help. One of the current treatment options for dry AMD, particularly for slowing down the progression of geographic atrophy, is nutritional supplementation. The formula we recommend is AREDS2. This is based on a large clinical trial conducted by the National Eye Institute. It specifically looked at combination of antioxidants and minerals shown to slow the growth of this atrophy, of geographic atrophy. It's important to highlight that this was a post hoc analysis. The study was something different, but what they studied was the growth of these atrophy patches and found that patients on the supplements, the rate of progression was less. So it's an option to consider in managing this. So until recently, we had no approved treatments for geographic atrophy or the advanced form of dry AMD, but 2 new therapies have been approved in the US that showed some progress in slowing the progression of geographic atrophy. The first is Syfovre, also known as pegcetacoplan, and this blocks complement C3, which is part of the immune system that contributes to the retinal damage. It is an injection in the eye. It's given every month, every 2 months. And after 2 years, it's shown to slow growth of the atrophy by 16 to 22%. So it doesn't stop the progression, it just slows it. So instead of 1 millimeter growth, it becomes 0.8 millimeter growth. So it helps to a degree. But one thing to note is the increased incidence of wet AMD changes on top of it. So from the control group having 2 to 4% development of wet AMD, it becomes about 6 to 13% in the treatment group. So quite a significant increase in terms of that complication, then requiring more injections. So Syfovre is approved in the US, but not approved in the UK or Europe, unfortunately. The second treatment is Izervay or ACP, and this targets complement C5. And in this, after 12 months, it showed a 14%, so 12 months, 1 year, so slightly less than the previous study of 2 years, showed a 14% reduction in the size of atrophy compared to no treatment. Again, it doesn't stop it, but reduces the progression compared to no treatment. And again, there's a small increase in wet AMD risk from 4 to 7%. Now, this is in the US available. I don't believe it's available in Europe, and it's being reviewed in the UK. So while these therapies don't reverse damage, at least they give us some possibility in slowing progression. Now, future treatments for geographic atrophy. These therapies are currently in phase 3 trials, which means they are the final stages before potential approval. ALK-001 is an oral tablet designed to slow retinal damage. In the SAGA trial, there was no significant difference in the first 24 months, sadly, but in the 6 to 24-month period, it showed a 15% reduction in atrophy growth. So there's some benefit there. ANX007 is an injection into the eye that blocks the complement C1, and this is in the Archer trial. It didn't meet its primary goal of slowing lesion growth, but fewer patients lost vision, so 69% reduced to 21%, which is a meaningful outcome. A second phase 3 trial, Archer 2, is underway. Elamipretide is a skin injection, so injection just under the skin that targets the mitochondria and the retinal cells. Again, it didn't meet its primary endpoint, but it showed that 43% reduction in the outer retinal loss, a marker of retinal stress. And that's being studied in a further trial called the RENEW trial. And lastly, Tinlarebant is another oral tablet treatment in the Phoenix phase 3 trial. It's designed to reduce the buildup of toxic byproducts in the retina and may offer a non-invasive option, meaning not injection in the eye, to slow down the disease. Now, these treatments aren't yet available, but they reflect a diverse and promising pipeline from eye injections to tablets to skin injections. Each one brings us closer to a more personalized, less invasive, effective care for AMD. Now, lastly, let's look at some of the most advanced technologies being explored, not just to slow AMD, but to restore vision. One exciting area is cell replacement therapy. This involves transplanting healthy cells into an area of damage to rebuild the retina and restore function. It's still very experimental, but early results are reassuring. A leading example is Oprigen, also known as RG6501, which is a subretinal treatment, meaning the cells are placed underneath the retina, and in early trials, patients experience improvement in vision, which is remarkable. Another frontier is retinal implants, a tiny electronic device that can stimulate the retina and send signals to the brain. These are being developed for patients with severe vision loss, and while they're still in early stages, they represent a bold step towards artificial vision. These technologies are not yet widely available, but they show us what's possible. In summary, the management of advanced AMD is evolving rapidly. We've come a long way from limited options to a growing landscape of treatment that offers real hope. So for wet AMD, the focus is now longer-acting treatment, one-time treatment to reduce the burden of treatment, and these innovations are helping us personalize care. For geographic atrophy, we're finally seeing emerging treatments where we had none before, from inhibition of complements to gene therapy and beyond. While they don't reverse damage, they offer a chance to slow progression. And beyond medication, lifestyle advice is key, smoking cessation, very important, and self-monitoring is essential. Finally, thank you for listening, and I look forward to answering your questions in the live Q&A.
Thank you so much, Luke, for an absolutely fascinating talk. And today's conference is called Hope for the Future, and I think that talk really delivered that. Really very, very interesting. And thank you again for joining us live this Saturday afternoon to take our questions. We've had lots of questions in the chat, so it's great that you're able to join us.
Thank you, Ed.
I'm going to start with a few questions on lifestyle, if that's okay. And I know you talked about some of this in your talk. What foods and vitamins are best for AMD, and do you think supplements are useful?
I think I tend to tell my patients lifestyle is key, because that's something we can change. We can do it ourselves, and it's also not just healthy for the eye but the rest of the body. We tend to say a good balanced diet is useful, carrots, etc., omega-3. So a good balanced diet rather than just focusing on one or the other, I think that's important. If we are already doing that, then I tend not to suggest supplements. If a patient just has mild changes in the eye. Of course, supplements are useful in patients with more severe changes and more advanced changes of macular degeneration. That's when the supplements have been proven to be beneficial in terms of reducing risk. So it's key to mention it's not a treatment. It doesn't improve vision. It doesn't work in 100% of patients, but it helps reduce the risk. So if someone is having severe changes, advanced changes, or intermediate forms of macular degeneration, then the supplements are useful. I'm cautious because these are not usually funded within the NHS. Some GPs don't prescribe it, and they do cost a bit of money. And we don't want patients with very mild disease spending a lot of money when they could just eat a balanced diet, which would be equally as good. And the studies have shown the supplements doesn't really work so well when it's just mild disease, and it's only proven to be effective when it's much more significant. So if you just have very early changes, I wouldn't rush to spend a lot of money buying these supplements, and just spending on good quality, healthy food and a balanced diet is probably the most useful thing.
Thank you. I think that point that the things that are good for slow macular degeneration in terms of lifestyle and food are good for us anyway. You know, it is broad health advice, so that's good. And sort of building on that a bit, and someone sort of wanting a bit more specific information. So with lifestyle, you talked about it, you know, being limited to slight and occasional drinking to slow progression. And someone's asked, what does that mean? You know,
what does that mean?
A month,
it's a good question. I think I can appreciate where it's coming from. When do I stop? When do I stop? What's the last glass you order? I think it's tricky with these studies. Most of these studies are large-scale studies relying on patient reporting outcomes and patient reports on how much they drink. To get the evidence, you need huge meta-analysis of different studies as well. And some studies won't show a difference, some studies will, and I think it depends on the quantity. If you dive deeper into the papers, they do compare it with no alcohol consumption and light use and heavy use. I think that's an easier way to qualify it. And it's incremental. If you're a light user, there's a slight increase in risk. You're not a light drinker, and you're a heavy drinker, it gets up higher. So there's no strict rule. Again, it depends if you drink heavily one day and the rest of the month you don't. So there's a lot of variations, and I think I'll be guessing if I were to tell you a specific unit or glass or brand. I think it's reasonable. I don't think we should abstain completely on alcohol. I think it has its purposes. Christmas is coming. There's always going to be reason to drink. But at the same time, again, it's the same advice before. Moderation, not excessive. I think 1 or 2 glasses isn't going to be dangerous or harmful. But any more than that, I would be cautious, especially if you already have a diagnosis of wet AMD. Some of the papers even looked at drinking and its alcohol and its effects, and it tends to affect the more early stages as well. So there's some results of that. So I think it's a cumulative effect. So I would definitely suggest, of course, drinking in moderation. I wouldn't abstain completely. I think that's a very difficult thing and probably unreasonable as well. But I think moderation, not excessive drinking, is probably the message that to send. And I'm sorry not to be able to give a prescriptive amount, and I wish I can, but I think it's sensible drinking, which I think it's probably the fairest option.
Which again just aligns to the sort of general medical advice anyway, doesn't it? Thank you. And turning to a sort of different aspect of lifestyle, someone's asked if high cholesterol is a risk factor for AMD, and also about the different forms of cholesterol and whether there's a different effect there.
I'm not certain on that, actually, and I think I'm sure there'll be studies, and I wouldn't be surprised if that were to prove some effect on AMD. It is very difficult. Don't have the answer directly for that. I think cholesterol has been shown to have some impact in lipid lowering medications with diabetes, in vascular health. People are looking at that in terms of statins to help with inflammation. So there's a lot of processes within the eye impacted by it. I think it's an area of future research. Nothing definitive, but I'm not surprised in the coming years we will get something more concrete to recommend and advise.
Okay, thank you. You say smoking is very bad for AMD and indeed again for general health. Does this include nicotine vapes and nicotine tablets? Do we know that?
We don't. The understanding it can be linked and it's associated. Most of, again, the studies have looked at smoking in general rather than nicotine vaping, etc. In fact, the smoking risk has been shown to be more related to the more advanced changes as well. That's something we strongly has been shown to be quite significantly related to advanced AMD. So definitely smoking, ceasing smoking and trying to stop smoking, and every efforts to do so is fully supported. Vaping and patch is probably a step better in trying to reduce the risk. Again, I'm not aware of efforts to look at whether that has a risk as well. I think in the future we will need to fine-tune the stratification of risk. But again, we're talking very small risk and very large numbers in large study with very inconsistent practices. So it's very difficult to be certain. But again, if you are able to reduce or stop smoking, but needing the patch as a transition phase, I think that's a step forward.
Thank you. I'm going to move on to some questions around treatments, and one we've been asked quite a few times in the chat is your views on photobiomodulation as a treatment for AMD, which I know is something that's of huge interest to the community.
It's a tricky one, and again, I feel I'm staying on the fence for this now. But photobiomodulation, in my personal opinion, I think the data isn't strong enough. This is just my personal opinion. I don't not representing Moorfields and saying that, etc. It's the papers. If you dive deeper into the studies, there's a lot of uncertainty. There's a lot of dropout. Even the control arm did improve. So there's a lot of question marks about it. It may prove to be a useful method to deliver treatment, but at the moment we can't say with certainty it's the right approach. It will be beneficial because we still have a lot of question marks when it comes to the studies. I think future studies are needed here to really understand it. We tend to get a lot of early results that are supportive, and when you really test the study or test the delivery or test the treatment with robust stats, it gets a lot of holes start appearing. So I'm cautious about it. I'm also cautious. I mean, some may argue that what is the risk and it's worth trying, which I appreciate because this is something accessible. But be cautious if you have dry AMD that is in itself correctly diagnosed, then I think it's probably fair to consider. Again, I wouldn't support it, and I'll be very cautious about giving false hopes to patients. But at the same time, it's something that can be considered. Of course, the risk is very minimal, if any. But of course, I caution if someone is younger and told with a diagnosis of AMD, but in truth is actually a genetic condition or an inherited dystrophy with mitochondrial problems. Having these treatments might exacerbate. We don't know for certain. So the trials have looked at dry AMD, and fair enough, it didn't cause harm, whether it caused benefit is uncertain. But I'll caution if the diagnosis is unclear. We don't know the risk of photobiomodulation if you have other conditions that are masquerading or mimicking as dry AMD, which is very common. So that's the only caution I would say at this stage. We hope it works because it seems a simple procedure that is done in a community setting, which is something all of us would like. And I've mentioned that about capacity constraints and early treatment, but we're just being cautious. We want the evidence to be strong and reliable before we fully recommend treatment with photobiomodulation.
Thank you. And I know you said it seems like you're sitting on the fence, but I think that just reflects the reality, doesn't it, of research and medicine. And I always think someone who's very completely confident one way or the other, you maybe want to have a little bit of caution, because it's often complex, isn't it?
It is. Thanks.
Are there any other current treatments for wet AMD beside the injections?
So the future treatments are on durability, which still relies on some form of injection, sadly. We haven't ventured out. Drop treatments have been trialed years ago with minimal effect. I think it's being reevaluated again now, but the data is very poor. We are focusing on, injections, but different models, different molecules. So the TK inhibitors, which I've mentioned earlier, is a step away from VEGF, which is what we've been doing for the last 15 years. And that's promising because it's a slightly different molecule that can be packed up in a little pellet that then slowly releases the drug over time. I think that's probably where we're heading in the next few years, because we've seen the phase 2 and 3 trials, and they are promising. So we hope that it's a once a year or twice a year injection that can control the disease, which is what all of us would like or prefer. Gene therapy is, of course, the next stage, where you're making your eye produce your own drugs, and that's just a single injection. And that's, again, the next stage we hope to get the results. But again, phase 1, phase 2 studies seem to be very promising, but still needles, sadly.
Yeah. And building on that as an interesting question, a possibility of a one-time injection, of course, sounds fantastic, or less regular injections. But would the drug companies oppose that, as they want to keep selling their treatments more often?
True. I mean, I think that's... I don't mean to speak freely. I think there's always that element, isn't it? Pharma is fantastic in terms of driving and developing new drugs. Industry will always do that, which is great, and we rely on the innovation in industry's appetite, of course, for profit, but at the same time developing new drug, which is what we want at the end of the day. And it's a very good question about long-acting drugs. I think with the state of the biosimilar drugs, the cheaper off-patent drugs, which does the same thing, and it's fantastic. Actually, it's a very good thing that's coming from the NHS about supporting its use, because we're showing here that we want drugs that are effective for patients, and drugs that are of course cost effective for the system, and actually allowing that pushes drug companies to have longer acting drugs that then negates that cost, i.e. you spend a higher number but one injection, therefore there is still business for it. Again, a permanent cure would be the holy grail. I think from clinicians and scientists, yes. From industry, I think from speaking to a number, there is appetite for that. So again, I don't mean to be cynical, and I tend to be mostly, but I feel that there is that conflict. But among clinicians, that's what we want, and we're pushing forward, and I'm sure that's what we're going to work towards. So I'm sure the drug companies will support development of it, but of course we have the NIHR, the Macular Society, etc. A lot of other independent funders that are hopefully going to push that side.
Yeah, thank you. And we've got lots more questions, but I'm conscious we haven't got much time left before our next session, but we'll get through as many as we can. And apologies if we don't get to everyone's questions. You talked about lots of treatments. Are any of those able to restore vision as opposed to just slow things or stop things getting worse?
I think for wet AMD, yes. Wet AMD, treatment does improve vision. We've seen that 30-40% gain, 15 letters, meaning 3 lines in your chart. With dry AMD, not quite. I think that's the difficult treat. With dry AMD, we don't have data or treatment that can improve vision. The idea is slowing vision loss, slowing growth of the atrophy. In the future, hopefully, cell replacement therapy may be an option that can be considered. Again, that's so early stages, so I'm really cautious about promoting that at this stage because we're still waiting for more advanced, more detailed studies to prove its efficacy and safety, but it points to the right direction. I mean, most of what we've done in retina has been preservation, and improvement to a degree. But replacing tissues, just like what we do with cataracts or joints or knee replacement, we're not quite there yet because it's such a specialized tissue. It's like brain tissue, neural tissue that is only fixed with scar tissue currently. That's how our body fixes things. But if we can guide the replacement to get more differentiated cells that function in the right way, that would be key. So as yet, for wet AMD, treatment does improve vision to a degree, but for dry AMD, we don't have anything that's successfully and proven to be able to improve that vision.
Thank you. And I think probably just time for one more question. And apologies again if we didn't get to a question you've asked. Someone's asked about monitoring changes if their macular degeneration has already taken their central vision. What are the things that you can look out for?
So what we tend to recommend is very difficult if you have central vision loss and trying to assess whether you have new wet changes that's happening. And also we have to balance that with the outcome. Having wet changes that doesn't cause symptomatic change, does it justify repeated needles to the eye with the risks associated with it? But what we tend to tell patients and ask patients is still to monitor each eye one at a time every couple of weeks. And what you're looking for is the edges. If you have a dark area at the center or blurred area at the center, is it progressing? Are you getting new distortion in the peripheral edges of that area? And that becomes important, especially when it's the bottom half of your vision, for walking downstairs, pouring tea, etc. Or if it's just off center where you're using it to read. So again, that's key. So functionally, is it impacting an important part of your vision? And if there is early changes there, then it's good to just get it checked, because we have seen patients with geographic atrophy, the dry changes, with a new wet change just at the corner, and that can bleed and scar and affect vision. So we still want to treat that promptly. So self-assessment, very difficult, I appreciate, when it comes to the peripheral area. But if it's not symptomatic, then reassuringly, it's not going to harm you or affect you. But if it is starting to become symptomatic in an area that you notice, then that is a sign that is impacting an important part of your vision. So again, do present and get that checked within a week or so that we can treat promptly.
Well, thank you again, Luke, for a brilliant presentation. Really, really interesting. And thank you for answering so many of those questions. Fascinating answers. So thank you for spending your time with us this Saturday afternoon. And we'll wish you all the best for the rest of your day. Take care.
Thank you so much. And thanks everyone for listening.
Bye.